Hi, my name is Benjamin Teeter. I am an associate professor at the University of Arkansas for Medical Sciences in the College of Pharmacy. I'm also an investigator in the Center for Implementation Research here. I will be talking today about disparities in unique populations, focusing on rural populations. My research program is focused on implementation science. Specifically, I hope to improve cancer prevention through the application of implementation science. Most of my work focuses on evidence-based interventions in rural community pharmacies. I focus in that area specifically because 90% of the US population lives within 5 miles of a pharmacy. So it's a great opportunity to increase access to healthcare. Specifically, I'm interested in increasing access to preventive services for rural underserved populations to reduce disparities. So some of my work has focused on HPV immunizations and increasing immunizations in rural areas, but it's also focused on screenings, whether it's cancer screenings like colorectal cancer, mental health screenings, or even substance use disorder screenings provided in rural community pharmacies. Some of the work has even looked at naloxone dispensing and opioid overdose risk counseling in these rural settings. This talk is about HPV vaccination in rural Arkansas and using community pharmacies to improve HPV vaccination. So Arkansas has the highest incidence rate of HPV-associated cancers in the United States. And part of the reason for that is that the vaccination rates in Arkansas are very low, and they're even lower in rural areas. In Arkansas, 41% of the population lives in a rural county, and that's compared to 14% of the population that lives in rural counties in the United States. So it's a large percentage of the population in the state that lives in rural areas. And these individuals are less likely to access preventive care for a number of reasons that include a lack of access to healthcare providers, a lack of knowledge and education about the importance of preventive care, and a lack of trust in healthcare and the government or recommendations from the government. Another thing that is difficult for rural populations in Arkansas is that Arkansas has very few primary care providers per capita. And pediatricians are even more difficult to find in rural areas. So most of the practicing physicians in these rural areas are family medicine physicians. And in these clinics, these family medicine clinics, more and more they're getting out of the vaccination business. It's not profitable for them, and they don't see the benefit from stocking all childhood and adolescent vaccinations. So this is also a tough thing for HPV vaccination in Arkansas. So the Vaccines for Children program, or VFC, provides free vaccine to providers that enroll in the program. And these providers can administer this vaccine to children at no charge, but participation in the program is really low. When we started this project, only 4% of Arkansas physicians were enrolled in VFC, and that hasn't improved that much since the start of this project. So the local health unit or the local health department was the sole resource for VFC vaccines in 20 of Arkansas's 75 counties. So there weren't many places that children that were eligible for VFC could get vaccinated. Pharmacists can participate in the VFC program, but at the start of this program, none were in Arkansas. And in fact, in the country, the number of pharmacies that participate in the Vaccines for Children program is less than 100. So participation is very low. So what we wanted to do in this project was first figure out the barriers and facilitators to pharmacy participation in VFC. We also wanted to see what barriers and facilitators there were to pharmacist-provided HPV vaccinations and get a better idea of what pharmacists and physicians thought about collaborating to provide more HPV vaccine. We then wanted to develop a pharmacist-physician collaboration model and identify and develop some supportive implementation strategies using an evidence-based process known as evidence-based quality improvement. And then we wanted to test that model and the supportive implementation strategies on relevant implementation outcomes. So for the first objective, we conducted interviews with pharmacists, physicians, and parents of adolescents in rural areas. And we identified some barriers and facilitators. First, pharmacists were interested in participating in VFC, but they thought cost to enroll was a major barrier. There's startup costs associated with enrolling in VFC. You have to have a separate refrigerator for your vaccine stock. You also have to have separate temperature monitoring equipment, and you have to have specific roles designated for VFC enrollment. We also found that parents support having their children vaccinated in the pharmacy as long as there was communication between the pharmacist providing the immunization and the child's primary care provider. They want to make sure that there's a comprehensive, complete vaccination record for their child at their primary care provider's office. Primary care providers also said that they supported offering adolescent patients the option to receive HPV vaccination in their community pharmacy, as long as it didn't impact well-child visits. They said parents often think of the well-child visit as the visit for vaccinations, although that's not what the well-child visit is for. It's for the physician to get, a look at the child as a whole. But because of the association with well-child visits and vaccinations, they thought if they receive vaccinations elsewhere, they'll no longer think the well-child visit is important. So knowing those barriers, we first thought, hey, we can address the initial barriers and then move on to developing a collaboration. So I was able to secure a small grant from the Arkansas Immunization Action Coalition and purchase those refrigerators and temperature monitoring equipment for 10 rural pharmacies. I then also contacted the Arkansas Department of Health and the state VFC coordinator and asked them about the enrollment fees and if there was anything that could be done about those initial fees to get enrolled in VFC. They were very helpful and waived all enrollment fees because they want more providers to enroll in VFC. And in fact, that's actually a permanent change. There are no longer enrollment fees to participate in VFC. The next step was to recruit a partner organization because we had to have somewhere to put those refrigerators with their temperature monitoring equipment. So I was able to partner with a small regional grocery chain that has pharmacies in their stores, and they agreed to enroll 10 of their pharmacies into the Vaccines for Children program. So the next step was to develop a collaboration model and implementation strategies. We had 4 evidence-based quality improvement sessions, and these are sessions that involved pharmacists, physicians, parents of adolescent children, and the entire research team. And we brought all these individuals together to figure out what we wanted the collaboration to look like. So what we decided was, if the collaborating clinic didn't participate in the VFC program, they would refer all of their VFC eligible patients to the pharmacy for vaccination. And the way that would be done is the physician would send an e-prescription to the pharmacy for same-day immunization. Now, it's not required in Arkansas that a pharmacist has a patient-specific prescription for HPV vaccination, but this was just done so that the pharmacist would know to expect a patient, and they could put it in their software. They can just give a little heads up that the patient might be coming in to get the HPV dose that day. On the other hand, if the clinic did participate in the VFC program, the clinic would provide the first dose and then offer the parents of the patient they'd offer them the option to receive the second dose in the pharmacy. And again, the provider would administer the first dose and then send that e-prescription to the pharmacy for the second dose so that the pharmacy could put that in their dispensing software and set up their reminder text message alerts in their software. Additionally, we thought if a patient just shows up in the pharmacy and requests the HPV immunization without a referral from a provider, the pharmacist would administer the vaccine and then remind the patient of the importance of their annual well-child visit, as well as notify that child's clinic for their records. So when they fill out their form to receive the HPV vaccination in the pharmacy, they ask, what's the primary care provider's name, and contact that provider and tell them, hey, your patient was in the pharmacy and we administered their first dose. They're due in 6 months. We'll follow up in 6 months, but we also reminded them the importance of their annual well-child visit. So with those known barriers and facilitators, we also developed some supportive implementation strategies. We had patient-facing materials. So those included buttons that are worn by all pharmacy and clinic staff, posters that were hung in pharmacies and clinics, bag stuffers for all of child prescription bags, stickers for all prescriptions, regardless of whether they were for a child or not, and text message reminders sent at specific intervals so that they could remind the patient when they were due for their next dose. There were also provider-facing materials. So there was a letter from pharmacy to clinic to introduce the service and invite them to collaborate. Basically, this was, hey, we're starting this program. We would love if you were involved, and this is how we'd like it to work. Contact me if you're interested or if you have any additional questions, and I'd be happy to talk to you about it. We also created talking points for the pharmacists and physicians about HPV vaccine. So this included, how to give a strong recommendation to a parent for the vaccine, some minor training in the presumptive method for HPV vaccine, and how to talk to hesitant parents about the vaccine. And lastly, we created a referral portal. We call it a portal, but it was just a way for two-way communication between the pharmacy and clinic. It's basically just a designated email address for this collaboration. So the pharmacy has a specific email address, and so does the clinic. And the only thing that they communicate about using those email addresses is their collaboration and what they've done in regards to HPV vaccine. So these are the materials, the patient-facing materials that we created. So you see there's a button that says, ask me about cancer prevention. We use this language to not have vaccine out in the forefront. Thought this might get more parents to ask their physician or pharmacist about, what is this button about? We also have these stickers that would go on the prescription bags. Each one has a fact about HPV. HPV is extremely common. HPV can cause deadly cancers. Boys and girls can get HPV. And it also has, the state of Arkansas in the back to feel like, this is specific to this state. There's also the bag stuffer there with a fact about Arkansas having the highest rate of HPV-associated cancers in the US, and those posters that are hung in both the pharmacy and the primary care clinic. So the patient and the parent are seeing consistent messaging, whether they're at the pharmacy or in the clinic. So here's some more of the materials we developed. This is the letter that the pharmacist could use to contact clinics in their area. And these are the 4 text messages sent from the pharmacy that basically say, hey, you're due for your second dose in 6 months. Then one that comes 2 weeks before they're due for their second dose, one that comes on the day they're due for their second dose, and then one that comes 2 weeks after to say, if you haven't gotten your final dose, you're due and you need it for full protection from the vaccine. So please contact or come by the pharmacy. So now that we had this collaboration model and the implementation strategies, we want to pilot test them. So we have 3 pharmacy implementation sites, and the main outcome we're interested in is adoption, which we are defining as HPV vaccination rate. So this is the vaccination rate, the number vaccinated out of the eligible population. And we estimated the eligible population using county level census data of how many kids are in the county that are on Medicaid and eligible. What's the percentage of the kids in that county that received the HPV or that have received HPV vaccine? And then using those numbers and some of the Arkansas Immunization Registry to estimate an eligible population. Our secondary outcomes are implementation outcomes of feasibility, acceptability, and appropriateness. We're going to conduct interviews with pharmacists, clinic staff, and parents to try to get a better understanding of how this would work or if it would work in the real world and not in a study. So to share some preliminary results, these pharmacies, the 3 pharmacies, have all contacted nearby clinics and established a collaboration with at least one clinic. One pharmacy has established a collaboration with an FQHC. And so that FQHC provides VFC vaccines. So in that scenario, the first dose will be provided in the FQHC, and the physicians will give the opportunity or the option for the patient to receive their second dose in the pharmacy. The other 2 pharmacies have partnered with family medicine clinics that do not participate in the VFC program. So in those cases, all patients that are eligible that go into those clinics will be referred to the pharmacies for their HPV vaccine. So far, immunization numbers are pretty low, but we only started this pilot test a few months ago. So we've talked to some of the physicians and pharmacists that are participating in the project, and they assured us that this is typical for this time of year, and the immunization season for this age group is typically during back to school. That's when they're going to get their immunizations or they're thinking about their well child visits. So we are collecting data for a full 12 months, and we will continue until February 2024. So that's the basics on that project with the pharmacist-physician collaboration, I'd like to tell you about a few other projects that we are working on with rural community pharmacies and HPV vaccine. The first is a project where we're doing similar process to what we've done with pharmacists and physicians, but with pharmacists and dentists to improve HPV vaccination in rural communities. So instead of a physician referring to the pharmacy for vaccination, it's dentists referring. We're doing this because dentists see adolescents about 2 times a year for their dental cleanings. That's more than pediatricians or primary care providers often see this population. And it's likely more than even pharmacists see this population, because usually pharmacists are recommending things to parents of adolescents and not to the patient themselves. So this will be similar to the project I previously described. The other project that we're working on is with embedding community health workers in these rural pharmacies to go out into the community and provide outreach and education about HPV vaccine. And the idea is to train a current employee, usually a pharmacy technician, to become a certified community health worker, and then do that work on a part-time basis. So they're typically normally doing their technician duties, but maybe 1 day a week, they're going out into the community, going to back to school events, fall festivals, those kinds of things to promote the vaccine and refer back to the pharmacy for vaccination. So thank you for the opportunity to talk to you today about rural community pharmacy and the role that they can play at improving HPV vaccination. If you have any questions for me, please feel free to contact me at the contact information listed at the bottom of this slide. And thank you for your time.